All right, we're at 8 o'clock. We will start on time today. All right, welcome everyone to Geriatric Medicine Grand Rounds. As is tradition, at the end of the academic year, each of our fellows picks a topic and presents grand rounds on that. And they have a lot of different ways they choose their topic. Often there's something they come across during the year that really grabs their interest, and they want to take a deeper dive on it. So the first of our 4 fellows who will be presenting over the next month or so is Dr. Jasdeep Kaur, and she is going to talk to us about mindfulness meditation in patients with mild cognitive impairment and their caregivers. And thank you so much, Jasdeep. Go ahead.
Good morning, everyone. Thank you for being here today. I realize that we have just about 6 weeks left until the end of this fellowship year. So I do want to take a moment to thank my clinic preceptor, Dr. Parikh, all the rotation attendings, Dr. Bennett, Shanitra, my fellow classmates, and all the staff members, patients, and their families for teaching the essentials of geriatrics and for making this year a very memorable, transformative, and revitalizing year in many ways. So thank you for being here for this Grand Rounds. As a trainee in geriatrics, I believe that the most challenging part of geriatric patient care is addressing the intangible aspects of aging, the fears, anxiety, losses, grief, stress that's related to aging, to nearing the end of life, and even more so related to cognitive and functional decline that's seen in dementia. This is far more difficult for the family than for the patient, as the family tries to provide compassionate care at home and delay placement into higher level of care. For me, the biggest challenge was how to deal with this psychosocial, uncomfortable, emotional stuff. And as I searched for these answers, I came to a realization that as we address the physical world of maximizing resources and medications, that it is the internal world of emotions, personhood, well-being that also needs attention. Tony Robbins, who's a world-renowned personal coach, teaches that when there is something you're unhappy with, then you have 2 options. Either you can change your action or you can change your perception to change the outcome. As I continue to find a way to better address the psycho-emotional needs of my patients and their families, I wonder how I can help them change their action or change their perception. And I wondered if meditation practices would offer an effective way. There is plenty of evidence that meditation practices are helpful in addressing many psychological disorders. However, that research has not been done effectively or to a bigger extent in other populations. So I chose to look at mindfulness meditation out of the various different types of meditations, because there is now a rising number of studies that are looking at how mindfulness meditation can help us take care of our patients and address several psychological issues as well as health-related issues. The outline for this talk will be, we will start with a short experience in meditation. We will go over a patient case. We'll talk about what mindfulness meditation is, what its benefits in older adults with MCI are, and what mindfulness meditation can offer for caregivers. And then we will reach a conclusion for ourselves. For disclosures, I don't have any disclosures, but I do have slides from the internet, so the credit goes to the internet for those pictures. By the end of this talk, I hope that you gain a better understanding of the benefits of mindfulness meditation, and you feel more empowered to recommend or not recommend it to your patients and their caregivers. So let's do meditation. At this point, I want to introduce a friend of mine, Akansha Batra, who is a doctoral student at UCSF. She is a public health researcher with a focus on mental health and general well-being. She is a certified breathwork and meditation instructor and has been meditating for over a decade. She's a yoga. Thank you. Here are some resources for mindfulness meditation for providers, for patients, and caregivers through the same association.
Jasdeep, I'm sorry to interrupt, but it doesn't look like your slides are advancing.
Oh.
There you go.
Awesome. Thank you. So here's some resources for the Sky Club, Healing Breaths for physicians, and Art of Living for patients and caregivers. Let's take a moment. I want to take a brief poll. If you can answer in the chat box, or you can unmute yourself and tell us what you feel. And the question is, do you believe that the state of mind that a person is in determines the course of action in that moment? We'll just take a few seconds. And I can't see the chat, so Kate, I don't know if.
You have a mix of A's and C's.
All right.
Yes, definitely.
All right. All right. I request that you hold on to this, this belief as we go through the slides. The state of mind can have a significant impact on the action and your perception in that moment. Let's look at a patient case. This is a case of Mr. B, who is one of my clinic patients. He is an 84-year-old gentleman with Alzheimer's dementia, with behavioral issues. He lives with his wife at home. Over the last year, he's had some worsening of the behavior, and he is needing more assistance at home. He is fast 6A stage for dementia. For his behavior, we started him on prazosin a few months ago, which has resulted in some improvement. However, he continues to have perseverative behaviors, repeatedly asking questions about testosterone, focusing on erectile dysfunction. This creates a lot of stress for his wife. And every time I see the patient and his wife, she is distressed. I try to see them about once a month. She's feeling overwhelmed because of the progressive dementia. She recently took the patient to the ER after he was having some breathing problems, and those breathing problems were related to allergic rhinitis. And she constantly worries that he's in the last stages of dementia and that he is going to be passing away. She is struggling to care for him emotionally, and wife several times asks the same questions. She's again worried about dementia and losing patient. She, mostly worries about why is he doing the things that he's doing? Why does he ask repeatedly the same questions? Why doesn't he understand? She has difficulty sort of troubleshooting, simple problems. And she is not willing to pursue additional help at home or send the patient to adult family home or assisted living home. She's worried, she's overwhelmed, she's quite stressed, she's basically burnt out. Let's look at what are some of the problems or challenges that we can identify here. And for the sake of time, I'm going to mention some of the ones that are more pertinent to this talk. While there's a lot of education issues and repeated education that's necessary for both patient and family, I do wonder what is going on in the mind of the patient in terms, even though he's going through dementia, what is going on with him mentally? Is he depressed? Is he anxious? Is he stressed? What is his mental health like? for his wife, who's his caregiver. She's irritated, she's annoyed, she's angered by his requests. She is angered by his questions. She is, again, very clearly distressed. I worry about her mental health. And as a provider, I wonder, if there is stress, there is insomnia, is this early depression? What is her and the patient's mental health like? Is this burnout? And what can we do? While we try to educate the wife in the 1 hour or 30 minutes of the appointments that we have, that educational aspect, all the booklets on dementia and the information that's available online, the various resources that are available through the VA, sometimes they're just not enough for the patient or the family to feel that they have the toolkits necessary to take care of their loved one. It is pretty clear that many patients and their caregivers need something extra that can help them learn new ways of dealing with the same problems. And a key aspect of their problems is really their mental health and their state of mind. JAMA in 2012 published a paper that included non-pharmacologic management of behavioral symptoms in dementia, and it's a really handy table that we use that talks about different things we can do to help patients and their families to, troubleshoot some of the issues, including having some easy activities for the patient to do, doing caregiver education and support. I remember my clinic preceptor teaching me about the art of distraction, that, teaching families about changing the subject topic so that, the patient doesn't continue to focus on the same thing. That also helps the caregiver as well. Also, another teaching point that, don't argue with the patient or, from a caregiver standpoint, just go along with the story as much as possible. And again, while we try to go over these strategies in clinic, sometimes there's just either not enough time or even there's not enough practice at home. I feel that we notice a lot of the times that the patient's behaviors are like waves in an ocean. They come and the caregivers feel that they need to stop those waves or they need to stop that behavior. But really the trick is to be able to learn how to surf those waves or how to go along with those behaviors in a way that is sustainable. The patient case that we looked at is not unique. It brings to our awareness a much bigger problem at a national and international level. We can see that the aging population is getting larger in size. By 2030, it's expected that there's going to be 66 million people, geriatric patients who have dementia. So that's quite a huge number. That puts a significant burden on the healthcare system in terms of managing the symptoms. We already have very limited resources for taking care of these patients. And what this calls for is that we recognize that this is a significant burden on the healthcare system and that we need to provide care to patients and their families in ways that are not specifically relying on the healthcare system. So the purpose of this talk is to learn about how mindfulness practice can help take care of the aging population and their caregivers and help alleviate some of the burden on the healthcare setting. So let's look at some of the risk factors for developing cognitive decline. For the sake of time, again, I'm just going to share these risk factors. We all know there are non-modifiable risk factors, with age being the biggest one, and there are several modifiable risk factors. A systematic review was published earlier this month in JAMA Neurology that showed that the most prominent risk factor for cognitive decline and dementia is midlife obesity, actually in the last few decades, as well as physical inactivity and low educational status, along with midlife hypertension and depression, as well as obviously hearing loss. So now let's let's look at what are some of the societies saying about the burden of mental health and the modifiable risk factors. The National Institute of Health had a State of the Science conference in 2010, where they tried to address several different questions. And some of these questions were, what are some of the risk factors that are associated with the risk of Alzheimer's? What are some of the things that reduce the risk of cognitive decline? What are some of the therapeutic interventions that can delay the onset of Alzheimer's disease? And what are some of the therapeutic interventions that can help or maintain cognitive ability or function? Their conclusions were based on a review of published literature of adequately powered randomized controlled trials at that time, and this was back in 2010. One of the questions that is pertinent to this talk, more pertinent to this talk, is the question about whether there are therapeutic interventions that can improve or maintain cognitive function. And their review showed that cognitive training does have modest benefits on cognitive functioning, and that there is a small statistically significant effect on reducing the extent of age-related cognitive decline at about 5-year follow-up, and very small significant benefit on instrumental activities of daily living. However, they noted that more studies are needed to replicate the findings, and even a longer follow-up is needed. The key take-home points from the NIH were that there is evidence that supports the link between depression and dementia, in that depression increases the risk of cognitive decline and dementia. There is evidence that supports that cognitive engagement and training can improve cognitive status. And there's evidence that physical activity, whether that is low physical activity, that increases the risk of cognitive decline and dementia. The key point here is that they pointed out that there is association between poor mental health in terms of depression and cognitive decline. Now let's look at 8 years from then. In 2018, Lancet developed a comprehensive set of guidelines to make mental health more accessible worldwide. And they came up with a stepped care approach for management of mental health. And they called their sort of synthesis of knowledge and recommendations as the Lancet Commission on Global Mental Health. If you have time, please consider reading it. It is a very interesting set of guidelines about the state of mental health worldwide and what are some of the things that need to be done to address the mental health situation worldwide. They also talked about how depression and the presence of depression in older life, in older age, as well as the high success rate of fatal suicides in the older population. They brought attention to the fact that with the rising older population, the dementia burden is increasing, and that we need to work on reducing the modifiable risk factors, which is one way that we can reduce this burden. And that because there's a large number of patients that will need mental health resources and there is scarcity of resources worldwide, they recommended that low intensity psychological interventions be used across the spectrum of severity as the first phase of stepped care of depression. They too noted that cognitive training therapies offer promising therapeutic options. The Lancet Commission highlighted the association between cumulative depression burden over the lifespan and the risk of cognitive impairment and dementia. And they noted that depression might also have a causal role in the onset of physical frailty. They talked about the fact that there is association between having low level of education in early life and the higher risk of developing dementia as well. And they called attention to improving that modifiable risk factor. They also recognized that more research is needed to better understand the mechanisms and the associations between the modifiable risk factors and the ways to improve outcomes in mental health. Lancet, one of their conclusions was that interventions aimed at strengthening social and emotional competencies, often focusing on enhancing emotional regulation and packaged as life skills education, mindfulness or yoga, can have preventive effects. Mindfulness meditation has been associated with structural changes in parts of the social brain network, such as the cingulate cortex and the medial cortex and the amygdala. So the key points from the Lancet symposium was that they highlighted that the effect sizes of psychological treatments typically ranged from moderate to large, and that the side effects were relatively rare associated with the psychological treatment options, and that the evidence was as strong for these treatment options as pharmacologic options. Especially for mood, anxiety, and trauma-related disorders, and that they said that there is no consistent evidence for the superiority of either in terms of attaining remission, but psychological therapies seem to have a greater enduring effect than pharmacologic therapies. So again, what they highlighted was that non-pharmacologic interventions, specifically the psychological interventions or therapies, are supported by strong evidence for their effectiveness across a wide spectrum of mental health conditions. And they also pointed out that there's a major bottleneck for providing mental health, and that is that there's just not enough specialists available to provide mental health. So we need to look for other resources that can provide some help. Moving on to NIA, the National Institute on Aging, on their website too, they have a section on maintaining cognitive health, and they talk about, within that website, they talk about managing stress, as stress being an important risk factor that contributes to cognitive decline. And they also talked about relaxation techniques and practices such as mindfulness that can help manage stress. Managing stress can improve brain health, which in turn helps with improving the function. So far, we've looked at a patient case that is reflective of many patients that we see in families that we care for, that there is psychosocial distress, there is emotional distress, and there's difficulty accepting the present. There are worries about the impending future. Basically, we recognize that their mental health is suffering. There are various society guidelines that also point out the association between mental health and cognitive health and function, and they note the importance of cognitive training, psychological support, and mindfulness. So let's learn more about the benefits of mindfulness in our patient population. Mindfulness meditation is a practice of being present in the present moment and acting non-judgmentally towards events. Just as what we experienced a few minutes ago, there are many ways of doing it. You can do it while sitting, walking, doing mindful movements, listening to music. It is a form of cognitive training, and it involves specifically doing attention switching, which is the task of disengaging from a disturbing thought, to selective attention, which is redirecting attention to another thought. And it generally, there is evidence that it enhances self-regulation and awareness, and it involves neuroplasticity in various regions of the brain. There is a lot of research on mindfulness meditation. There's like more than 900 studies. When I initially set out to do this Grand Rounds presentation, I was overwhelmed by the number of results that are produced when you type in mindfulness meditation in the Cochrane database or even in PubMed. There is evidence that mindfulness meditation works for anxiety, depression, substance abuse, eating disorders, insomnia, chronic pain, and various other things. There's emerging evidence that There is some benefit in terms of inflammatory response and immune function. There is additional evidence that, or studies that are being done in stroke patients and transplant patients, so subgroups to see if it is helpful, in those patient populations. Many sort of short studies that show that short-term memory is improved with mindfulness meditation or other forms of meditation. However, there are lots of problems with the research studies so far, and as has been pointed out by Lancet or the National Institute of Health, that while there is strong to modest evidence that mindfulness meditation and psychological therapies actually work in the field of psychiatry, there is actually just a lack of high quality evidence in areas other than psychiatry. We will start to look at some of this evidence very briefly. This was published in 2021. This paper looked at factors that were associated with successful non-pharmacologic interventions for people with dementia. They reported many outcomes, but they only focused on quality of life and the neuropsychological symptoms and depression. This was a qualitative systematic review. They looked at about 36 randomized controlled trials. What they noted was that half of the studies in this review actually reported positive effects and the other half did not. And their conclusions were that, that it was difficult to predict. It was difficult to make out in terms of whether there are good enough studies or not, because some studies that they thought had rigorous designs did not produce the expected outcomes, while other studies that did not have the rigorous sort of study design, they still had positive outcomes. And so basically, they too again highlighted that we need better studies, better designs to look at whether mindfulness meditation can help in people with dementia. While there's lots of problems, some of the problems are that a lot of these studies are done in very small number of patients, like 10 patients or 20 patients. And so the generalizability of those studies is not so great. The results are mixed. Again, some say that the findings support while the others negate those findings. There are various different types of mindfulness meditation practices out there, so it's hard to find enough studies that are addressing just one type of mindfulness practice. Also, many studies have shown that you need experienced meditators as a control group as well, and experienced meditators are those that have greater than 1,000 hours of meditation, so that again can be challenging. Attrition rate is a huge problem, especially if there is a longer follow-up, and these studies generally do require longer follow-up. And it's frequently found that most of these studies have just a few months follow-up, and there's lots of design flaws in many studies, as well as having an appropriate control group that can truly assess whether the benefits are from meditation or from other aspects. So basically, the foundational problem with the research in mindfulness meditation is that mindfulness meditation is an umbrella term, and it encompasses various different types of meditation practices that target different regions and different outcomes. So that results in significant heterogeneity within the study designs and the comparisons and the outcomes. And that leads to the several limitations of studies, especially the generalizability and the heterogeneity of these studies. This was a key study. This was published in 2002 in JAMA. This looked at 3 cognitive training interventions. The study was titled The Effects of Cognitive Training Interventions with Older Adults. So this was a randomized control trial. They looked at whether cognitive training in the field of speed, reasoning, and memory can have beneficial effects. And what they found was that the effectiveness and durability of cognitive training interventions in improving targeted cognitive abilities. So their results supported that, and they found that They also found that there was a minimal functional decline across all groups because, and they noted that a longer follow-up is likely required. This was another way of interpreting this was that, so when they tested speed, there was an improvement in people who were doing cognitive training for speed. When they tested, or when they worked on reasoning, there was an improvement in reasoning. And when they worked on memory, that resulted in improvement in memory. So overall, the study findings were that cognitive training does result in improvement in the cognitive status. For this study, they did use people with mini mental scores of greater than 22, and their exclusion criteria was quite robust, which does not necessarily apply to many of our patients, though. Another systematic review tried to answer the same question, whether cognitive training can prevent cognitive decline. And they concluded that in older adults with normal cognition, the training improves cognitive performance in the domain that was trained. So that, again, sort of confirmed the findings of the previous study. And they found that, that there wasn't enough evidence in terms of preventing or delaying cognitive decline or dementia at this point. So they looked at different ways of doing cognitive training, and as mindfulness is one of them, we'll look at mindfulness specifically next. This one study looked at the effects of meditation and mind-body exercises in older adults' cognitive performance. This was a meta-analysis, and they looked at about more than 3,000 patients in that meta-analysis. And what they found was that in general, meditation and mind-body exercises improved cognition in the older people, and that depended on the type of the exercise. They also showed that the cognitive performance findings were significant when the length of the intervention was greater than 12 weeks, and that the exercise frequency was 3 to 7 times a week, and the duration was 45 minutes or 60 minutes. This study was helpful in sort of trying to help troubleshoot some of the problems that were happening in previous studies where it wasn't clear for how long people should be doing meditation, what should the session be, and how frequently they should be doing it. They also showed that not all forms of meditation were equivalent in producing the results. And from that meta-analysis, they showed that, for example, people who really want to work on their speed, it was yoga that helped with executive function and processing speed, while the specific practice of Qigong improved global cognition and short-term memory and working memory. So again, sort of, going back to the point that there's various different types of mindfulness meditation practices, and the reason why we don't have consistent results is because different mindfulness meditation practices are targeting different regions in the brain, resulting in different outcomes. And so we can't compare one mindfulness practice to the other mindfulness practice. At this moment, I want to take a pause, and I know that I went over a lot of the stuff, so just want to pause and go over the take-home point, which is that mindfulness meditation, it is a form of cognitive training, and it can improve cognition in older adults. And we also learn from a lot of these studies, and we as geriatricians obviously know this, but that the aging brain can learn new things and it can improve capacity. So let's try to understand a bit on how mindfulness meditation brings about this change. This was a key study. It was called Meditation Experiences Associated with Increased Cortical Thickness. This was done back in 2005. Their hypothesis was that meditation might change brain's physical structure. So they used MRI findings to look at cortical thickness in 20 patient or participants that did insight extensive meditation. And what they found was that there was an increase in cortical thickness of the people who did meditation. If you look at the graph of C and or the figures of C and D, the blue is the meditators and the red are the non-meditators. In general, the meditators had a higher thickness than the non-meditators. And the top picture shows the areas that sort of lighted up when the meditation was being done. So it targeted specific regions like the insula, the prefrontal cortex, the left hemisphere cortex. And what they concluded was that meditation might offset age-related cortical thinning, and that this was this was the first sort of study that showed that that provided structural evidence for experience-dependent cortical plasticity that was associated with meditation practice. And this actually resulted in a huge increase in the number of studies that are being done in mindfulness meditation and how that affects cortical thickness. There's, again, we'll very briefly go over some of the other studies. There's another study that talks about the alteration in the brain and the immune function that is produced with mindfulness meditation. Then their conclusions were that a short program in mindfulness meditation produced some demonstrable effects on the brain and the immune function. And this figure just shows the antibody titers actually to influenza vaccine in participants who had done meditation. And the participants who had done meditation, they had higher titers to the influenza vaccine than those that did not. This study looked at the mindfulness practices and how that improves inflammatory biomarkers in the older adults with mild cognitive impairment. This was a randomized controlled trial. Again, a lot of information on the slide, I recognize that, but basically looking at various biomarkers. The orange is the mindfulness group and the blue is the control group, which is the HEP group or the health education program, which has been shown to be a more effective control for a lot of the mindfulness studies. And we can see that in these figures that the mindfulness group, which is the orange group, did do better than the control group. Again, a similar study showing the same in terms of Alzheimer's disease, patients with subjective cognitive decline, the effect of meditation and music listening on blood biomarkers. And again, their biomarkers were better in people who did the meditation than music listening. Another study which is relevant in this day and age and during this pandemic was done in Portland that looked at whether older people aged 65 to 90 would be okay with getting an intervention on the internet or online. And what this study showed was that that the older patients are okay with getting interventions online, and that one of the intervention was meditation, the other was education, and that both interventions were acceptable to participants, and they regarded both groups with equal credibility and acceptability. And that sort of suggests that online education can be provided to older adults as well as online meditation can be provided to older adults. And it is accepted by them. Although again, it was a small study with few patients. This study goes on to, again, to provide some of the supportive evidence that meditation causes structural changes in the brain in mild cognitive impairment or Alzheimer's disease patients. And it showed that the long-term meditation practice in people with MCI or mild AD led to cortical thickness and gray matter volume changes that they considered significant. This study, the following study looked at how mindfulness interventions for mild cognitive impairment actually led to attention-related improvements and neuroplastic changes. And this study was done over a period of 9 months. Again, some reassuring evidence and supportive evidence that mindfulness training can result in cognitive improvement. At least for a period of 9 months while the study was done. Again, a longer follow-up is missing on various studies. So at this point, I want to pause again and go over take-home point number 2, which is that, you know, while we recognize that there is scarcity of good and high quality evidence and studies, and while we await those studies, there is sufficient evidence that mindfulness meditation has lasting effects on brain structure and on neuroplasticity, as well as on cognition and mental health. And that the structural changes in the brain have not been seen to correlate with functional improvements. But again, we don't have good enough studies to really assess that and to follow that through for, you know, on a longer follow-up. Let's shift our focus to caregivers. At this time, there's more than 5 million caregivers for just Alzheimer's dementia, and their number is expected to rise over the next decade or so. Caregivers, as we know, suffer from insomnia and anxiety and mood disorders while caregiving for their loved ones. And it has been shown that that insomnia is the most prominent sort of health problem in caregivers. And it's thought to be secondary to the psychological distress of caregiving. The treatment for insomnia is recommended to be cognitive behavioral therapy for insomnia, which is CBTI, and that is recommended by the American College of Physicians and the American Academy of Sleep Medicine. However, that therapy is not available, in many places. It's not widely available. And so the following study, which is an ongoing trial, is looking at the caregiver. It's called the caregiver sleep study, and it has actually looked at the cost analysis of cognitive behavioral therapy and mindfulness based practices. And what they concluded is that the mindfulness-based practices cost a lot less and provide equal results in terms of treating insomnia in comparison to cognitive behavioral therapy. I recognize that actually I'm running out of time, so I apologize. I am going to try to go through the rest of the slides in a meaningful manner. There was a study that was a pilot control trial that looked at mindfulness meditation and education for dementia caregivers. And this was done in Portland again. And what they saw was that basically both mindfulness and education interventions decrease self-rated caregiver stress compared to the respite-only groups. And what that emphasizes is that our caregivers are in need of practices that can help alleviate some of the stress and can improve their knowledge base, which is difficult to achieve in a clinical setting in office visits and follow-ups. There was a sort of like a consensus or report published in 2021 that looked at the available evidence for managing the needs of caregivers for dementia. And what that showed was that, again, we don't have strong enough data or evidence that anything in particular helps. However, they recommended that programs like the REACH2 or the collaborative care models that include a multidisciplinary approach that involves teaching strategies about problem solving, skills training, or stress management, and support groups and education, that those have low grade evidence, but that is sort of the only evidence we have that it seems to benefit the caregivers. Another study looked at mind wandering and the benefits of that in terms of mindfulness meditation. And again, it showed that there was benefit. A lot of the people who are caregivers suffer significantly from mind wandering and ruminating thoughts. And mindfulness meditation has been shown to decrease both of that in as few as two weeks of practice. this one study was published in JAMA Psychiatry, looked at the benefits of cognitive behavioral therapy and mindfulness-based meditation for management of anxiety, and felt that both were equivalent. And again, a lot of our population suffers from, our caregivers suffer from anxiety, so it would be helpful to offer that to them as another option. This one study was done actually here in Seattle, VA, that looked at PTSD patients and to see if meditation versus cognitive behavioral therapy was equally effective. And they found that they were both equally effective, but mindfulness meditation resulted in a better improvement of their depressive symptoms. From the data that is available, at least for the caregivers, we recognize that caregivers are at actually higher risk for mortality and morbidity that is associated with insomnia, with stress, anxiety, and depression, as well as substance abuse. There is a strong to moderate level of evidence that mindfulness-based practices are equally effective as insomnia in treating, as equally effective as cognitive behavioral therapy in treating these above issues. And while there is data that is lacking in terms of specifically addressing the caregivers, there is existing data that helps support that mindfulness-based practices are effective in addressing these mental health issues. So as a final summary, I hope that we can see that mindfulness meditation again reduces insomnia, stress, and anxiety, that there's emerging evidence that mindfulness meditation can can improve like immune response and inflammatory responses. There's again a lot of studies that are going on it. I hope that in the next 5 to 10 years that we can have some definitive evidence in terms of the long-term benefits of mindfulness meditation. The studies so far do suggest that there are long-lasting changes in the brain structure and that there is increased in cortical thickness as well as in attention. And what that means is that it could possibly delay cognitive decline. It may preserve their cognitive function. However, again, better designed studies are necessary with longer follow-ups to really test that out. We've also seen that mindfulness meditation is cost-effective, or more so than cognitive behavioral therapy, at least when compared with cognitive behavioral therapy for insomnia. And just as a take-home, I hope that you can see that mindfulness meditation is another toolbox for addressing mental health needs for our patients and for our caregivers. And I hope that you would consider mindfulness meditation as a recommendation for your patients and for their caregivers to help address their state of mind and their mental health as a result of caregiving and as a result of undergoing aging. And with that, I would conclude my talk.
Thank you so much, Jasdeep. I think we have time for 1 or 2 questions, if anybody has one.
Yeah, this is Elizabeth. Jasdeep, thanks for that really fascinating presentation. Can you hear me okay?
Yes.
I was wondering if you could tie that evidence that you covered with us back to the patient and how you would, practically implement that approach with either or both the caregiver, his wife, and he himself.
Yes. So, the VA gave me a prescription pad because I needed it to give a prescription to a patient. So instead of giving one prescription pad, they gave one prescription page. They gave me a whole pad. And so I thought that a good use of that, a number of prescriptions, would be to write some of the recommendations on the prescription, because that sometimes helps patients and families remember better. So I started writing a prescription for mindfulness meditation for the patients and their caregivers. And one of the ways this can be tied back to the patient and his wife is that what I recommended to them is that there are online ways of or options for doing mindfulness meditation. That way they don't have to leave the house. She and the patient can both try to do some sessions online. And she's going to attempt to do that. I have seen that done with other patients. And I think that it works definitely, at least for the caregiver. For people with mild cognitive impairment, I think it would work better because they would be able to pay attention and develop some of the skills. And in terms of caregivers, if they are able to do it at home, then that can provide them with some additional sort of skill sets or tools that they can use to address the issues they have.
Thanks. That's great.
Thanks, Jasdeep. That was great. Another question about what resources, like what online resources specifically would you give the caregiver to do?
The VA, actually, I talked with Chris Fredrickson, who's our VA social worker for the Jerry Pact Clinic, and she said that there are resources for mindfulness through the VA as well. But in the beginning of the presentation, when we were doing meditation, actually, I guess my slide didn't show up, but one of the slides has resources. Let me see.
Yeah, it was real quick.
The one that I have shared is the artofliving.org for the patients and caregivers. But they have different programs for providers and other people. But even on YouTube, when we type in mindfulness meditation or guided mindfulness meditation, there's lots of videos that go over that.
Cool, thanks. Another thing that might be helpful for some patients who don't have internet access could be something from the library. Like public libraries often have, CDs or other audio resources that could potentially be helpful.
Yes.
All right, we're a little bit over, but Angela, you had a question.
Oh, yeah, I just wanted to make a really quick point about your talk, just because I'm looking at helping a group design a study for a cognitive intervention. I took a bunch of screenshots of your slides. Control groups are really hard when your intervention is something like this.
Yes.
So thank you for pointing that out, Jasdeep. What should your control group look like? Not only for, scientific validity, but also to keep your patients in a 9-month study. Like, hi, you're going to be in a study and we'd like you to do nothing. Thanks.
Yes. That, I totally understand. And I think that with all the data, I thought that, with the studies that had like a true control where they didn't do anything, a control where they had like a HEP program or health education program where it has some of the components in terms of education and physical training.
Right.
That was helpful. And then having true mindfulness group. But within mindfulness, if it involves physical activity, then I think the study requires a physical activity control group as well. And if mindfulness involves music, then you probably would need a control group that includes listening to music as well. So I think it ends up being like 4 different groups or 5 different groups with 3 of them control groups.
And so yeah, and there's, and again, I know Kate said we're over time, but I did want to just point out that the National Institute on Aging, people who give us money, they like the health education control group for what that's worth.
Yes.
So write that down, everybody. They don't like the do nothing control group. So thank you so much. I love it. I took lots of screenshots.
You're welcome. Thank you. I hope this helps. I'm sorry I sort of sped through some of the slides. I lost track of time, but I'm glad that I was able to finish it.
Great. Well, thanks so much, Jasdeep, and thanks everyone for your great questions and for participating in the meditation. That was great. It's a first for Jerry Grand Round, so thank you. All right. Have a good weekend, everyone.
Thank you, everyone.
Thanks, Jasdeep. Bye.
Bye.